For nearly 150 years, the Dallas Morning News has brought quality journalism to not only Dallas, but to Texas and the entire country. And now we bring that same reporting to your morning with the Dallas Morning News podcast. Every weekday in just 5 minutes, you'll hear the top headlines from around the region and learn how it affects Dallas and the world beyond. Listen and subscribe to the Dallas Morning News podcast, wherever you're listening right now.
Hello, I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. And today's topic, we are going to be diving into caring for the hypothermic patient. Of course, before we do that, let's take a minute for our listener shout out. This one goes out to Amy, who says, I would have never passed NCLEX without Med-Surg Solution. I still use it now to review after being an RN for 2 years. I passed NCLEX super fast, hearing Nurse Mo's voice throughout each question. Starting in clinicals, I was able to follow my instructors, RNs, and preceptors in job training, knowing my stuff and being able to have confidence communicating with doctors. This is priced well for what you get, and she is down to earth and easy to understand. Trust me, you want this. Amy, thank you so much for sharing your experience with Med-Surg Solution and how that helped you as a student in clinical and now as a practicing nurse, and also helping you pass your NCLEX. I'm so glad that it helped you. So if you're wondering what Amy is talking about, Med-Surg Solution is a video-based program where I explain about 60 common disease conditions in a very succinct, clear, and easy to understand way, basically taking out all the fluff and just putting in the key things that you need to know. I'll have a link in the episode notes so that you can check it out. So today we're talking about hypothermia. So what is hypothermia? So hypothermia is that condition that is present when the body temperature is below 35 degrees Celsius, and that is 95 degrees Fahrenheit. And it occurs when the body loses more heat than it can create or absorb through external means. And it has a really significant effect on physiology. Now, hypothermia is usually due to exposure to cold, either being outside in cold weather, being submerged in cold water. It can also be due to medical conditions and even some medications. So first, let's talk about how the body regulates temperature. So temperature is regulated by the hypothalamus, which receives input from thermal receptors throughout the body. And when the hypothalamus detects a drop in body temperature, the initial response is to try to produce adequate body heat through things like shivering, increased muscle tone, and increases in the basal metabolic rate. Specific changes that occur include peripheral vasoconstriction, so that we're not losing heat through those vessels being wide open near the surface of the skin, so peripheral vasoconstriction, and increases in hormones such as epinephrine and thyroid hormones. And then the brain is also fascinating. It's also going to cause the individual to have behavioral changes. And that could be adding more clothing, seeking a heat source, or seeking shelter and increasing activity. So let's look at some medical conditions that cause hypothermia. Now, again, it's usually due to exposure to cold, but we could also get hypothermia from medical conditions. And one of those is myxedema coma. So this is when long-term hypothyroidism has not been treated, and the body has had very low thyroid hormone for a long time. This can lead to disruptions in the body's ability to maintain homeostasis, and this homeostasis regulation includes temperature regulation. Another condition that can lead to hypothermia is hypoglycemia. Since the body uses blood glucose as a key source of energy, hypothermia can result when blood glucose levels are significantly low. And then there are burns. With burns, especially larger burns, think about what happens to that body, the body's protective layer. It's completely destroyed and disrupted. And we're going to lose body heat through those areas of burn. And this is why burn units are kept so much warmer than other areas of the hospital. You walk into a burn unit and it feels like you're walking into a sauna almost. It's really, really warm. And then neurological conditions can lead to hypothermia. So, neurological injury and neurodegenerative disorders can disrupt the hypothalamus, leading to impaired temperature regulation. A common neurological injury is cerebrovascular accident or a stroke. And then mental health disorders. Individuals with mental health disorders, including dementia, including psychosis, including substance abuse disorders, may not display appropriate behavioral responses to cold stress. So, that individual is not going to be seeking shelter or seeking heat or adding more clothing, for example. So, they are high risk for developing hypothermia. And then I mentioned earlier that medications could cause hypothermia. So, yes, definitely can. Either the medication can cause hypothermia or the hypothermia can be exacerbated by certain medications, especially when multiple medications that can induce or cause hypothermia are taken together, or if a medication is taken in excess. So, I'll talk you through some of the key ones. One of those is antipsychotics. Antipsychotic medications such as olanzapine and clozapine have been shown to cause hypothermia, especially in individuals with other risk factors such as being of older age, having hypothyroidism, having a stroke, or renal disease. And then anti-seizure medications. Some anti-seizure medications, such as valproic acid, can impair the body's ability to regulate temperature, thereby leading to hypothermia. And then benzodiazepines, opioids, and tricyclic antidepressants can cause hypothermia due to disruptions in thermoregulation, especially with overdose of these medications. Lithium is another one. Lithium toxicity can reduce core body temperature. And then general anesthetics. So, anesthesia inhibits the hypothalamus and causes peripheral vasodilation. Both of these things make it difficult for the body to respond appropriately when exposed to cold. And note that a really cold environment is an operating room. We keep these rooms very cool for infection prevention purposes. So, treating hypothermia in the recovery period is very, very, very important. And monitoring the patient's temperature continuously during surgery is also very, very important. And then we have oral anti-diabetic medications. Medications that lower blood sugar can impair the body's ability to generate heat from glucose, thus impairing the body's ability to compensate when exposed to cold temperatures. And then the last ones are alpha adrenergic agonists and beta blockers. These medications block components of the sympathetic nervous system, which can blunt the body's ability to compensate for cold exposure. And of course, it is worth mentioning, though not a medication, but alcohol. Alcohol can also lead to hypothermia during cold exposure due to impaired shivering, hypoglycemia, peripheral vasodilation, and hypothalamus dysfunction. And to that, I would also add maybe not displaying appropriate behavioral responses to cold stress. Maybe if someone's had a lot of alcohol, they're not going to be putting on more clothing or seeking shelter or trying to get to a heat source, especially when, very, very, very impaired. All right, so now you might be wondering, well, how do we measure body temperature accurately? So, to really evaluate hypothermia, in an appropriate way, it's very important to measure what's called the core body temperature, which is essentially the temperature of the internal organs. And there are several ways to measure core temperature, but the most accurate methods have been found to be through a pulmonary artery catheter or an esophageal thermometer. Now, a pulmonary artery catheter is quite invasive and not often used. So, what you'll see most often is an esophageal thermometer. And these probes are placed into the esophagus and positioned at the level of the heart to essentially show the temperature of the myocardium. Remember, core temperature is a measurement of the temperature of the internal organ. So we're looking at the temperature of the myocardium with an esophageal thermometer. Note that this method is only used in sedated or unconscious patients since it can stimulate the gag reflex and cause vomiting and aspiration. Other forms of core temperature measurement that you could see used for hypothermic patients are bladder temperatures, rectal temperatures, and nasopharynx temperatures. So, looking at a bladder temperature, we get that through a special Foley catheter. They are equipped with little temperature sensors on them, and this enables you to measure body temperature continuously. Now, the evidence shows that as long as the urine flow is within a normal range, then bladder temperatures can align closely with core body temperature, but only really in states of normothermia, because bladder temperatures are going to react to core body temperature changes more slowly than, say, an esophageal measurement does. When I was working in the ICU back in the day and taking care of hypothermic patients, we used a lot of these Foley catheter temperature probes and a lot of the rectal temperature probes. The ICU now uses esophageal thermometers. So they're keeping up with the evidence and changing practice to be more evidence-based. But you might still see a bladder temperature probe used. And if it is, you could advocate for an esophageal thermometer probe if your patient is hypothermic. Again, if your patient's normothermic or close to it, that bladder temperature is probably going to be somewhat accurate. Another one is that rectal temperature. Studies show that rectal temps don't necessarily correlate super great with core body temperature, and readings can take longer to reflect changes when compared to that esophageal measurement. Some challenges with rectal temps include the presence of stool in the rectum, especially hardened stool in the rectum, can make it difficult to get the probe into the correct position. It can be uncomfortable for the patient. The probe must be inserted at least 15 centimeters into the rectum so that it is near the large arteries of the pelvis, which is where we're going to try to get that reading from. And in patients with hemodynamic compromise, rectal temperatures are going to read lower than true core temperatures because we're placing that probe near a large artery, so it relies on really adequate blood flow in order to get a good reading. So, not super commonly used these days in most critical care units, but you could still see them used. And not to say that rectal temperatures aren't really helpful. They're used a lot in pediatric patients, right? With not the continuous monitoring type, but the inserted thermometer, the inserted rectal thermometer. In a ICU environment, you might see a rectal temperature probe that is a continuous type of probe. It's a long, skinny, thin. It kind of looks like a Foley catheter, but very narrow. And then that is inserted into the rectum. Again, not as reliable as an esophageal thermometer probe. And then the other one I mentioned is the nasopharynx. This location is able to provide reliable measurements of core temperature and is most commonly used during surgical procedures. The probe is inserted to a depth of 10 to 20 centimeters in adults, so it lies near the internal carotid artery. As you can imagine, probably pretty uncomfortable on your awake patient. All right, let's take a quick break, and when we come back, we'll talk about signs and symptoms of hypothermia and hypothermia treatment.
For nearly 150 years, the Dallas Morning News has brought quality journalism to Dallas, to Texas, and to the entire country. And now we bring that same reporting to your morning with the Dallas Morning News Podcast. Every weekday, in just 5 minutes, you'll hear the top headlines from around the region and learn how it affects Dallas and the world beyond. From City Council to the Texas Legislature, from DFW to downtown, from Carrollton to the Cowboys, we'll keep you up to date on the entire Dallas-Fort Worth area. So, wherever you're listening right now, subscribe and listen to the Dallas Morning News Podcast.
Now looking at the signs and symptoms of hypothermia, and it can be categorized into 3 different stages: mild, moderate, and severe hypothermia. In general, hypothermia causes the body's physiologic functions to slow down, though it's important to know that there could be some compensatory mechanisms occurring early on in mild hypothermia. So let's take a look at that now. So remember at the very beginning when I said hypothermia was when the body temperature is below 35 degrees. Well, we actually have kind of like that pre-hypothermia stage or mild hypothermia when the body is 35 to 37 degrees Celsius. Remember, normal is going to be right around that 37 degrees. So anything below that's technically hypothermic, but it is mild. And what a patient could experience with mild hypothermia are things like confusion, maybe some impaired judgment. They could have slurred speech. They could have ataxia. They could have tachycardia, tachypnea, shivering, and hyperglycemia. And those would all be kind of compensatory mechanisms. The body's trying to generate some heat, trying to raise the basal metabolic rate. Again, that was tachycardia, tachypnea, shivering, and hyperglycemia. The patient could also have diuresis, so be putting out a fair amount of urine. They could have a gastric ileus and even impaired clotting. And some patients can even go into DIC, disseminated intravascular coagulation. Now, that is a whole other topic, but I talk about it in another episode, and that is episode 173. I'll put a link to that in the show notes so that you can click right on that and go and listen to it right after this one. And then next, we are in that moderate hypothermia range. This is where we're officially below that 35-degree threshold, and the range is 32 to 35 degrees Celsius. So you could still have, the problems with mild hypothermia, like the clotting abnormalities, the diuresis, the ileus, where we're going to start adding on more problems. So the patient could now at this point be hallucinating. They could have lethargy. They could have bradycardia that is not responsive to atropine. Usually when a patient has bradycardia, not caused by a high degree heart block, we can give a little atropine and their heart rate comes up. This is not going to be the case in moderate hypothermia. The patient's going to become hypotensive, have decreased cardiac output, cardiac arrhythmias, hypoventilation, muscle rigidity, and decreased shivering. They're no longer able to do these compensatory things to generate more heat. And when you look at, something interesting, I mentioned hallucinations. When you hear stories about people dying of hypothermia out in the elements, they're often found without their clothing on or with a lot of their clothing removed. And that is because the brain is just not functioning properly and the person may begin to feel like they are too hot and even remove their clothes, which is of course going to exacerbate the hypothermia. So that was moderate hypothermia. And then we have severe hypothermia, and that is in the range of 28 to 32 degrees Celsius. So this is very, very cold. For reference, 28 degrees Celsius is 82.4 degrees Fahrenheit. If you're not yet used to kind of doing those translations in your head, now you can see how cold that patient is when they are at 28 degrees Celsius. So at this stage, we've got all kinds of problems. We have a complete loss of thermoregulation ability at this point, coma. The patient could have absent ocular reflexes. We're going to have continued deterioration in blood pressure and cardiac output. They could go into ventricular fibrillation, asystole, pulmonary edema, apnea, oliguria. So they're not putting out enough urine. They've had all this diuresis. Now they're not putting out enough urine. They may have something called pseudo rigor mortis, where they basically appear like they are dead. And they could have impaired glucose, hypoglycemia or hyperglycemia. So that was severe hypothermia. So to summarize, depending on, obviously it's going to depend on how cold your patient is. Some key things you are watching for with your hypothermic patient are clotting abnormalities, cardiac arrhythmias, pulmonary edema, and hemodynamic compromise. So something to think about. I worked in a trauma ICU for a bit, and it was very, very, very important that patients who were cold or hypothermic, who were in trauma, receive rewarming very quickly. And that makes perfect sense, right? Let's say you've got somebody with bleeding wounds, maybe internal injuries, maybe external injuries, and they're actively bleeding. If they are cold, they're not going to be clotting adequately. So getting that patient warmed blood products or warmed IV fluids was a really crucial part of the care for that patient so that we wouldn't kind of exacerbate that bleeding issue with the clotting abnormalities that are associated with hypothermia. So that kind of leads us into how we are treating hypothermia. Obviously, the key treatments are going to be stopping further heat loss and rewarming the patient. Additional treatments are, of course, going to be aimed at addressing any of the complications that come up. And as you saw, I mentioned quite a few. This could include cardiac dysfunction, it could include DIC, and we also want to make sure that we're maintaining a patent airway. If your patient loses consciousness, they're not going to be able to maintain their airway, so they're going to be intubated. So again, key treatment, stop the further heat loss, get that patient warm, and deal with complications as they come up. So first thing we're going to do is stop that heat loss. If the patient was in water, we want to get the wet clothing off, dry the patient, and insulate the patient, get some blankets and whatnot on them. If the patient is taking medications that induce hypothermia, and I read several case reports of patients who were hypothermic because they were taking one, two, or maybe even more different meds that cause hypothermia. So medication stopped, patient does a lot better. So if your patient's taking meds that induce hypothermia, likely the situation is going to be that the MD is going to stop those meds and consider alternatives for that patient. Now, once we have stopped the heat loss, or basically that contributing factor, we're going to rewarm the patient. We have quite a few options, and it will basically depend on the level of hypothermia. So looking at mild hypothermia, which is again 35 to 37 degrees Celsius. This is something I deal with all the time as a recovery room nurse. Lots of times our patients come to us at core temperature. Well, I'm not saying we're measuring core temperatures. We're measuring tympanic artery temperatures, but we'll get a temperature below 36 degrees, 35.7 or something like that. So that patient has mild hypothermia. And what we're doing with this patient is we are putting heated blankets on them. We are turning on the little bedside heater for the patient and basically getting their body up to safe levels in that way. We can also provide warm fluids to drink for a patient that is awake. And for the most part, these are enough to increase core body temperature. Now, the general rule of thumb is a rate of 0.5 to 2 degrees Celsius per hour for increasing body temperature, okay, in that mild hypothermia. Then we have moderate hypothermia. And to recap, that is 32 to 35 degrees. So external rewarming is often utilized in patients with this level of hypothermia. So this is definitely going to include warming blankets, that forced warm air type warming blanket, or some heat packs placed strategically on the body, the chest, the back, the axilla, places like that, not in the periphery, but in the core. And then looking at severe hypothermia, and though it's not common, you could have a patient with a temperature even below that. So severe was 28 to 32 degrees. You could have a patient below 28 degrees. So anything in this range, basically below 32 degrees, is going to be considered severe. And based on the extent of that severity, we're doing some pretty aggressive rewarming. And this is going to be internal rewarming, or what is called core rewarming. And there are several options available for core rewarming. One of those is warmed IV fluids. And the IV fluids are heated to between 40 and 42 degrees Celsius. And if the patient has significant blood loss, we are also looking at warmed blood products to utilize in that patient, like I mentioned, that I saw a lot in the trauma unit where I worked. We can also do heated lavage of the pleural or peritoneal space. Now, these are invasive procedures that require the placement of tubes, so they can take some time to initiate. And then you could see heated and humidified oxygen utilized via an endotracheal tube or an oxygen mask, though I'm thinking if a patient is that cold, they're not conscious, so they're likely to be intubated. And this also helps prevent heat loss through respiration. One of the ways the body loses heat is through respiration. And then extracorporeal core rewarming, or ECR, is another pretty aggressive treatment for hypothermia. And this includes hemodialysis, continuous arteriovenous rewarming, extracorporeal membrane oxygenation, or ECMO, and another option is cardiopulmonary bypass. So of these options, hemodialysis is the most commonly used as it is pretty widely accessible, though it is important to note that the patient's blood pressure must be high enough to tolerate the procedure. And of course, we're doing hemodialysis with warmed dialysate solution. And hemodialysis can increase core body temperature by 2 to 3 degrees Celsius per hour. So it's a lot faster than, like I mentioned earlier, putting warm blankets on the patient, which might get them to 0.5-ish degrees Celsius per hour. This is going to be much more aggressive. So to recap again, that first priority is to stop the heat loss and insulate the patient, and look at any precipitating causes, which could potentially be medications. And then we obviously are rewarming the patient depending on how severe the hypothermia is. So I hope that helps you understand a very interesting concept, and definitely something that you will see if you work long enough in the clinical setting, especially if you work in the emergency department or in an ICU. And I really hope to see you back here next week. I believe we're going to be diving into a foundational pharmacology concept. I'll go ahead and say it because I'm 90% sure this is what I'm going to be talking about. We're going to be talking about first pass metabolism so that you understand what that means. So I really hope to see you back here for that next week. Now, if you are a new student in nursing school or a struggling student in nursing school, I want you to take a big breath and then exhale a big sigh of relief, because I've got you, my friend. I have broken down what makes nursing students successful in my free guide, The 20 Secrets of Successful Nursing Students. I'm going to put a link in the episode notes so that you can easily go and grab your copy of that free guide today. And I'd also like to remind all my listeners in the United States, if you're listening to this now, when it is aired on October 3rd, I would like to encourage you to register to vote if you have not yet done so. Go to vote.gov to get information about registering to vote in your state before the registration deadline. And it could be different from state to state, so that's why you want to check your individual state. And even if you're listening to this at some other time of the year, go ahead, make sure you're registered to vote, get in there so that you can vote for local elections as well. Voting isn't something that just happens every 4 years. If we want to have the country that we want to live in, then we have to stay involved, we have to stay informed, and we have to voice what we want. And we do that by voting. So go to vote.gov and make sure you are registered to vote. I will see you back here next week. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Have you ever wondered what the science says about certain foods, products, or treatments? Does chiropractic actually work? Should I only buy organic foods? Are GMOs actually harmful? Is adrenal fatigue real?
We've got you covered. The goal of the Unbiased Science podcast is to dispel misinformation and misconceptions across an array of science and public health topics. We love to debunk myths and help arm our listeners with information so they can make evidence-based decisions. Make sure to tune in to the Unbiased Science podcast to get all of your questions answered.